Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board-certified nephrologist and clinical specialist in hypertension. Today's topic, my approach to hypertension. Before we get into that, make sure you check out the other videos at this channel. Check out bcnephro.com where you'll find articles not only on this subject, but on a wide range of nephrology topics. I'm also on Instagram at bcnephro. Links to all will be in the description below. But now, let's get into it. I'm often referred patients with difficult to control hypertension, and here's my approach, things I think about in this assessment. First, I'm always considering doing a 24-hour ambulatory blood pressure monitor to exclude white coat syndrome. Second, I need to make sure that I do a careful medication review, including over-the-counter medications, to assess for medications that can cause hypertension and also to see if the antihypertensive regimen is optimal. These first two things assess for apparent or pseudo-resistant hypertension. The next two things serve as an initial screen for secondary hypertension and also can help guide treatment. These include a renal evaluation, which should at minimum include a metabolic panel, urinalysis, and renal imaging, and a hormonal evaluation, which most often includes an aldosterone and plasma renin activity. I'm going to get into each of these aspects in more detail. At the end, I'll go through a stepped approach to the use of antihypertensive medications, and make sure you stick to the end where I'll go into some tricks I have up my sleeve as a nephrologist in these difficult to control cases. First, 24-hour ambulatory blood pressure monitor. This assesses for white coat syndrome, which is when the blood pressure is at target without medications in the ambulatory setting but elevated in the healthcare setting, and white coat effect, where the blood pressure is above target with medications in the healthcare setting, but controlled to target outside the office. It also assesses for nocturnal dipping. Normally, when we sleep, the blood pressure decreases by about 15%. If it doesn't decrease by at least 10%, the patient is classified as a non-dipper. Non-dipping is a risk factor for adverse cardiovascular outcomes and may be a clinical clue to the presence of obstructive sleep apnea. When reviewing the 24-hour ambulatory monitor report, it's important to know that the normal 24-hour average is not less than 130/80, it's less than 125/75. This is because we need to take into account the nocturnal dipping. The reports also often break down into awake and a sleep average. The normal awake average would be less than 130/80, and the normal sleep average would be less than 110/65. Second, medication review. Here I'm looking for medications, including over-the-counter ones that can cause hypertension. Common ones include NSAIDs, VEGF or tyrosine kinase inhibitors used in oncology, estrogen-containing oral contraceptives, decongestants, or stimulants such as ADHD medications. I'm also looking to see if the antihypertensive medication regimen is optimal. Suboptimal regimens would be one without a diuretic, with low doses, less than 50% of the maximal recommended dose, and medications that are not synergistic. So renin-angiotensin system blockers are synergistic with thiazide diuretics and calcium channel blockers, but they're not synergistic with beta blockers. And using two renin-angiotensin system blockers, such as an ACE inhibitor and an angiotensin receptor blocker together, would also not be synergistic. Now we're going to go into evaluation, which includes a renal and hormonal evaluation. So the renal evaluation is going to begin with a metabolic panel to assess for a decreased GFR. Kidney disease may be the most common cause of secondary hypertension. It's also going to allow us to look at the electrolytes, specifically the potassium and bicarbonate. If there is hypokalemia and metabolic alkalosis, this may be a clue to the presence of hyperaldosteronism. Now, there can be kidney disease even with the normal GFR, and we assess for this with a urinalysis and renal imaging, most commonly a renal ultrasound. If there's proteinuria, there may be an underlying GN, and this helps guide treatment because a renin-angiotensin system blocker should be used in these cases. Some things we can find on renal imaging include polycystic kidney disease, chronic hydronephrosis, or sequela of vesico-ureteral reflux. I also look for asymmetry in kidney sizes, unilateral renal atrophy on the renal ultrasound. If this is present, this would be a clue to the potential presence of renal vascular disease, renal artery stenosis. I typically do not screen with a renal artery Doppler in most cases. I don't find this test to be particularly sensitive. If there's a patient where I have a high index of suspicion, such as diffuse atherosclerotic vascular disease, maybe they also have an abdominal bruit, there's renal asymmetry, there might be a high renin hypertension. In these cases, the go-to test would be a CT or MR angiography. I would only do the renal artery Doppler if there was a contraindication to the CT or MR. Now, hormonal evaluation. I find measuring the aldosterone and plasma renin activity to be extremely helpful. First, the aldosterone-renin ratio is the screen for primary hyperaldosteronism. When assessing this, it's important to remember you not only need an elevated ratio that's greater than 20 to 30, but you also need an elevated aldosterone. If the plasma renin activity is very low, less than 0.5, this can drive a high ratio without an elevated aldosterone and would not be a positive screen. Even if there is not evidence of primary hyperaldosteronism, I find these tests to be helpful. If the plasma renin activity is low, less than 0.5 to 1, this is classified as low renin hypertension and is a clue that there might be salt or volume-mediated hypertension and the diuretic regimen should be intensified. If the plasma renin activity is high, greater than 5 to 6, this will be high renin hypertension and may be an additional clue to suggest the presence of renal artery stenosis, renal vascular disease. The other hormonal test is plasma-free metanephrines. This will screen for pheochromocytoma. I don't always do this because pheochromocytoma is very rare, but some clues to its presence are paroxysmal hypertension associated with tachycardia and diaphoresis. These patients also often have orthostatic hypotension. It's important to remember that there are a lot of false positives here. If it truly is pheochromocytoma, the levels are often very high, greater than 4 times the upper limit of normal. Lesser elevations can be found with medications such as tricyclics and with physiologic stress. Now, an optimal stepped approach would be starting first with either a renin-angiotensin system blocker or thiazide diuretic. Second, adding the agent not used in step 1. Third, add a dihydropyridine calcium channel blocker. This is something like amlodipine or extended-release nifedipine. Fourth is a mineralocorticoid antagonist. I typically use spironolactone. I typically don't have to go higher than 25 milligrams. Spironolactone is more potent than eplerenone, and I find that most patients do not get side effects such as gynecomastia at the 25 milligram dose. The next step would be to use a vasodilating beta blocker such as carvedilol or nebivolol. I don't like labetalol because I find it has more side effects, and metoprolol, although good for cardiac issues, is not a great antihypertensive. Now, after this, there are several options we can go to. First, if we think there is still a sodium or volume mediated to the hypertension, we can use a long-acting loop diuretic such as torsemide. Now, in most cases, I don't combine the loop diuretic with the thiazide. If you do, you need to monitor very closely because there is a significant risk of causing worsening kidney function or hypokalemia. The next thing we can do is to use a potent vasodilator such as minoxidil or hydralazine. A third option here would be to use an alpha blocker such as doxazosin or prazosin. And finally, there's clonidine. Although clonidine is very potent, I prefer not to use it because it has a lot of side effects and there is a risk of rebound if the patient is not adherent. Now, I'll get into the tricks I have up my sleeve as a nephrologist. So there are certain relatively minor adjustments I can make that I find to be very effective. The first thing is I'm looking to change hydrochlorothiazide to chlorthalidone. Even at the same dose of 25 milligrams, chlorthalidone is more potent and has a longer half-life. The second thing I can do is if the patient is already on a loop diuretic, such as furosemide, I can change it to a longer-acting loop diuretic, such as torsemide, and may do this if the patient has significant heart failure or edema. If they're on a low dose of furosemide without heart failure or edema, I might look to change this to the thiazide chlorthalidone. In rare cases, I'll use the combination together. If I do this, I usually use one of them only every other day and make sure to monitor the metabolic panel for potassium and creatinine very closely. The addition of spironolactone is often very helpful, even if there's not evidence of hyperaldosteronism. Another thing I can do is if the patient is on a non-dihydropyridine calcium channel blocker such as diltiazem or verapamil, change this to a dihydropyridine such as amlodipine or extended-release nifedipine, which is more potent. And in my experience, sometimes I change amlodipine to extended-release nifedipine and see some additional benefit there. Now, if they're on the non-dihydropyridine, you have to make sure they're not on it for tachycardia, cardiac reason. If this is the case and you make this change, they probably should be on a beta blocker. And finally, if they're on a cardiac beta blocker such as metoprolol, changing this to a vasodilating beta blocker such as carvedilol or nebivolol can be helpful. So that's it. Thanks for watching. If you made it this far, you might as well hit like and subscribe. Please share this video with someone who you think might be interested in learning about this topic. It's spreading the message word of mouth that really helps the channel grow. Leave a comment or question below and look in the description. I'll have links to multiple other videos that go into more depth into some of the things I spoke about today. And until next time.